pulmonary assessment and severity scoring in the PICU and the PCICU to help us with our airway clearance therapy ordering. What is the PASS score and why do we do it? The PASS score is a set score of how we address what the patient is going on with the patient and how we feel that they are going to be served best as far as how we're going to clear the secretions or in their airways. We look at a number of different things. We look at their history of their pulmonary disease, whether they were premature, they have a history of pulmonary disease, asthma, CF, chronic lung disease, whether they're on any home medications or not, and if this is an exacerbation of what their disease is or not. And each one of those criteria gets a score from 0 to 2. We also look at whether they're here for a surgery or not. Obviously, if they're here for a cardiothoracic surgery, they're going to get a higher score than if they're here for a rod in their leg. We also look at their heart and what it looks like in general, whether they have any defects that cause them to mix their blood so that they're having lower saturations to begin with. We also look at if they're arousable, if you can wake them up, if they respond to you at all or not. We look at their respiratory rate, which is dependent on their age. There's a chart that you can look at to determine if their rate is appropriate for their age, whether they're retracting or not. And each one, the more severe the retractions, the higher the scoring is going to be. What they sound like when we listen to them, if they're wheezing, if they're diminished, the worse they sound, the more diminished they sound, the higher their score is going to be. What their chest x-ray looks like, whether it's clear, whether it's unchanged, whether it's worse than it was, whether they've got a lobe of their lung down, all of that's going to play in. And then whether they're coughing up any sputum or not, and what level they're on for oxygen. And whether, depending on their cardiac defect, whether they need oxygen to maintain a normal saturation or not. So we score the patient, taking into account all of these different things, and then we go to the team and we're like, hey, this is what the patient, we're supposed to go to the team and be like, hey, the patient scores this on their PASS score. And if it's higher than 5, then we know that they probably need a little help clearing their secretions, so we want to order some airway clearance. If they're lower than 5, typically they don't need that help. They're more of a normal ability to clear those secretions and such, and preferably not have us do airway clearance on them if they don't need it. Unfortunately, this is where we're have problems with communication with our team, and we're having a lot of our airway clearance protocols or therapies being ordered off protocol, which means the patient really doesn't need it. They're satting 98% on room air, they're coughing, they're getting all the stuff out, and they don't really need us to help them, but they're still saying, oh, we just want to make sure. So this is where we need better communication with our team about what is actually going on with the patient. Excuse me. So how do you decide what you're going to order for your airway clearance? It's kind of up to you what you order. Well, it's up to the team what they want ordered. Sorry. Usually it's AccuPap as a first line. If the patient doesn't get any better with that or gets worse, then they're going to go up to IPV, possibly the vest, or very rarely the chest QRS. Sorry. So I took a 6-week period of time from May 1st to June 15th, and I looked at all the patients that we have in the hospital, well, in PICU and PCICU, and looked at all the patients that were on vapotherm or oxygen therapy to see if, one, this protocol was being followed and we were doing our PASS scores, and 2, sorry, whether or not the therapies were being ordered on protocol or off protocol. I looked at almost 400 different chartings of patients on oxygen therapy. Okay, so I looked at all these charts that were, and some of them were repetitive patients, multiple days, multiple shifts, and to see if our protocols were being followed. We have roughly 80 people trained in these two departments. We just went through retraining on this pass score protocol to make sure everyone knows what they're supposed to be doing. Unfortunately, look at the chart, you can see that it's not being done as often as it should be. Night shift does better than day shift, and honestly, the cardiac unit does better than the PICU. Out of these 400 charting instances that I looked at, about 70% of them in day shift were not done for whatever reason, as opposed to night shift having 31% not done. Some of them didn't apply because the patient wasn't in the PICU, PCICU at that point in time, or in the night shift they left, or they were on BiPAP. Unfortunately, looking at these numbers, you look at them and you see that even though we have airway clearance therapies ordered, we're not sure that this is what the patient actually needs, and looking at them half the time, it's not what they need. And here's the charts, prettier in color. And then I had Melanie send out a red cap survey to ask why we weren't completing our past charting, just to see what the response would be, to see if we could get an idea of why people weren't doing this or not. The majority of them said that it was because frustration, because the team's not following the protocol. So there was a few that said that they didn't understand or lacked training in it. A lot of them said they were too busy or forgot, which if you're doing this on the first rounds while you're doing your assessment of the patient anyways, you're not going to forget. And then there was a couple that said other various reasons. So, as I stated, of those patients that were charted as having their pass score completed, I would say probably 60% of them were off protocol on their ordering. Was this addressed with the team? I have no way of knowing because I wasn't there. Is the team receptive when we do go to them? Not always. Sometimes they are, but other times they are not. All right, so what can we do to get the team and to get everybody to complete these pass scores, and maybe to get the actual medical team listening to us? Asked in the red cap survey what ideas we had to make it so compliance was better. And the top thing that people were saying was find a better way to explain why we're doing the pass score. Other things they said that we could do was take away unnecessary airway clearance therapies. Again, that's a big communication problem that we're having with the medical team. They suggested doing a pop-up window and documentation, which might not be bad. Like maybe we can find a way to link it when you click vapotherm, or it's right in there with the vapotherm or oxygen charting. I don't know. Have an alert sent out as a shift reminder. I don't think that's really feasible because I don't know. Having the attendants and NPs take the pass score protocol training. I think this would be great if we could get them to agree to it, because I think once they understood what we're trying to accomplish, it's a protocol that somebody in the medical field and their part of the medical field has signed off on. Make it run like the asthma protocol, which the asthma protocol, once the patient's on asthma protocol, we dictate the things that happen. Not a bad idea. Again, we have to get the medical team on board with that. And make the pass score meaningful on acute care floors too, which it should be. Any patient that's on oxygen should be receiving the PASS score. So my goal in doing this was to get an idea of how well we are doing as a respiratory team trained in these departments in assessing our patients. Unfortunately, we are not doing it very well, at least not in documenting that. So it's not necessarily an issue with the assessment, it's an issue with the documentation that needs to be done. How can we correct this? It needs to be a team-wide effort. And I think the only way we're going to get the team to listen to us better is if we actually are doing the documentation, proving what they were documenting, and then going and discussing it with them. Once we can get to the point where we are communicating better with our medical team and they understand what our whole purpose is of this protocol, then maybe we can get them more on board. Might not even need the training, they just need the communication to be better, and not just going to them and going, hey, this is off protocol, you need to DC it. No, we need to discuss why it's off protocol and get a better understanding of what they're thinking with what they want. We need to be able to advocate better for our patients. Any questions?